Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. And you probably already made the diagnosis from this image, right? You know this from a Gestalt look. Osteogenesis Imperfecta. Don't disappoint me now. We're going to be discussing this and much more in this presentation on bone pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Bone pathology. First off, we need to talk about achondroplasia. Now that literally means without chondrocyte growth. Achondroplasia. Achondroplasia is characterized by decreased cartilage proliferation in the development plate. Achondroplasia is the most common cause of dwarfism. Achondroplasia is related to an autosomal dominant activating mutation in FGFR3, fibroblast growth factor receptor 3. Overexpression of fibroblast growth factor receptor 3 inhibits growth. Most mutations of fibroblast growth factor 3 receptor are sporadic and related to increased paternal age. Because intramembranous bone production is unaffected, having short extremities with a normal-sized head and chest due to deficient endochondral bone formation is a clinical characteristic of achondroplasia. The formation of an endochondral bone matrix is characterized by the formation of a cartilage matrix, which is eventually replaced by bone. The formation of an endochondral bone matrix is the process by which long bones develop. Intramembranous bone development, on the other hand, is distinguished by the production of bone without the presence of a pre-existing cartilage matrix. Intramembranous bone formation is the process by which flat bones like the skull and rib cage form. Mental function, lifespan, and fertility are not affected by achondroplasia. Now, this is something that you know. Osteogenesis imperfecta. Osteogenesis imperfecta is a congenital bone resorption disease that results in structurally weak bone. And patients typically have this classic blue sclera. Osteogenesis imperfecta is caused by an autosomal dominant defect in collagen type 1 synthesis. Clinical symptoms of osteogenesis imperfecta include blue sclera, hearing loss, and multiple fractures of the bone. Note that the middle ear bones are also prone to fracture in osteogenesis imperfecta. And here we have an X-ray from a patient with osteogenesis imperfecta, right? And another patient, and another patient. And here we have more imaging from a patient with osteogenesis imperfecta. And more. And a picture. This was a rare occurrence of pyloric stenosis in an infant with osteogenesis imperfecta. Note the blue tinge of the sclera. Now let's talk about osteopetrosis. Osteopetrosis is due to a hereditary deficiency in bone resorption. To the right here, we can see a picture of a patient with osteopetrosis. Note the cranial deformity and thoracic scoliosis. Osteopetrosis causes abnormally thick, heavy bone that is brittle and easily fractures, as you can see in this x-ray. See how white it is? Because it's extra dense, thick. Multiple genetic variants exist for osteopetrosis, and carbonic anhydrase mutation leads to loss of the acidic microenvironment required for bone resorption. Clinical features that you should be aware of for osteopetrosis include bone fractures, anemia, thrombocytopenia, right, low platelets, leukopenia, right, low white blood cells, and extramedullary hematopoiesis due to bony replacement of the marrow space. In fact, impingement on cranial nerves due to bony overgrowth may cause characteristic neurologic symptoms based on the cranial nerves that are affected. Osteopetrosis most often causes vision and hearing loss. A carbonic anhydrase mutation causes renal tubular acidosis, while a lack of carbonic anhydrase causes poor HCO3 tubular absorption, which results in metabolic acidosis. Treatment of osteopetrosis is bone marrow transplant, since osteoclasts are derived from monocytes. And here we have features of bone from a biopsy of the iliac crest. Note that in A, we see severe osteopetrosis with minimal remodeling, including some vascular space. And in B, we can see osteoclasts with shallow resorptive pits. Osteoclasts were present and appeared normal in light microscopy. Now let's talk about Rickets, which is defective mineralization of osteoid that affects children. To the right here, we can see classic findings in a patient with Rickets. This chest x-ray is showing the buzzword rosary beads of Rickets. Osteomalacia is defective mineralization of osteoid that affects adults. Both Rickets and Osteomalacia are related to vitamin D deficiency. Vitamin D is crucial for bone health. Osteoblasts normally produce osteoid, which is the mineralized with calcium and phosphate to form bone. Low levels of vitamin D can result in low serum calcium and phosphate. In general, 85% of vitamin D is typically produced by the skin after exposure to sunlight. And 15% of vitamin D comes from diet. Activation of vitamin D requires 25-hydroxylation by the liver, followed by alpha hydroxylation by the proximal tubule cells of the kidney. On the other hand, active vitamin D raises serum calcium and phosphate by acting on intestines and kidneys. While the kidney enhances reabsorption of calcium and phosphate, the colon increases absorption of both substances. Additionally, the bone promotes calcium and phosphate absorption. Risk factors for vitamin D insufficiency include reduced sun exposure in northern latitudes, sorry Sweden, poor diet, malabsorption of fat-soluble vitamins, liver failure, and renal failure. Low vitamin D levels in children cause improper bone mineralization, which causes rickets. Common features of rickets include pigeon breast deformity, ricketic rosary chest, right? Frontal bossing, and a large forehead. Rickets is pathognomonic associated with buzzword pigeon breast deformity on chest x-ray. Also those rosary beads, right? Don't forget that. The pigeon chest deformity is the inward bending of the ribs with anterior protrusion of the sternum. Ricketic rosary in children is caused by osteoid deposition at the costochondral junction. Frontal bossing, or having a larger forehead due to osteoid deposition on the skull, is another symptom of rickets in children. Question. Never mind. Osteomalacia in adults is caused by inadequate vitamin D levels. Inadequate mineralization results in weak bone with an increased risk for fracture, right? You know that. And laboratory findings of rickets and osteomalacia include decreased serum calcium, decreased serum phosphate, increased parathyroid hormone, and increased alkaline phosphatase. Here we have an X-ray from a patient with rickets. Note the cupping. And in this picture, we have a visual of the widening of the wrist associated with rickets. And on this, we can see the legs of a 2-year-old with rickets. And here we have a patient with rickets vitamin D deficiency and dependency. Now let's talk about something that we see in our older population, osteoporosis. You future geriatric physicians out there, this is for you. Osteoporosis is characterized by reduced trabecular bone mass, which leads to porous bone with a higher risk of fracture. The peak bone mass reached in early adulthood and the following rate of bone loss are the two factors that determine osteoporosis risk. By the age of 30 years old, bone mass reaches its peak and is determined by hereditary factors such as variations in the vitamin D receptor, as well as diet and exercise. After peak bone mass is reached, approximately 1% of bone mass is lost annually. The decrease in bone mass may be slowed by weight-bearing exercise, strength training, and proper nutrition. Also note that estrogen is positively correlated with building and maintaining bone mass. Thus, once women stop producing estrogen, hence menopause, they are at increased risk of osteoporosis. In regards to osteoporosis, the most common forms are senile and postmenopausal. Clinical symptoms of osteoporosis include hip pain, distal radius pain, fractures in weight-bearing vertebrae that cause kyphosis and height loss, as well as bone pain. Bone density is measured using a dual X-ray absorptiometry scan, or also known as a DEXA scan. In order to rule out osteomalacia, which has a similar clinical presentation to osteoporosis, the serum levels of calcium, phosphate, parathyroid hormone, and alkaline phosphatase are normal. Treatment of osteoporosis includes exercise, vitamins, calcium, and bisphosphonates. Bisphosphonates are a type of medicine that promotes apoptosis of osteoclast, thus shortening that breakdown of bone. Contrarily, the use of estrogen replacement treatment is debatable and not currently advised. The use of glucocorticoids is contraindicated because it may worsen osteoporosis. And here we have light micrograph of an osteoclast displaying the typical features of an osteoclast. Note the foamy cytosol and the multiple nuclei. Osteoporosis is here in this picture showing the differences in the matrix. And here we have an osteoporotic elderly female going on a jaunt in Japan. And in regards to osteoporosis, we can see here in the X-ray on the top the fractures that are present. And on the bottom, we see an X-ray of the humerus showing severe osteoporosis, right? Now let's discuss Paget disease of the bone. Paget disease of the bone is due to the imbalance between osteoclast and osteoblast function. We have this Paget's disease of the right innominate bone in a man of 80 years of age. Paget disease of the bone often manifests in late adulthood with an average age of more than 60 years old. The cause of Paget disease of the bone is unknown, but it might be viral. One or more bones are involved in a localized process that does not affect the entire skeleton. There are 3 stages of Paget disease of the bone, which include osteoclastic, mixed osteoblastic osteoclastic, and osteoblastic. The end consequence of Paget disease of the bone is bone that is dense, sclerotic, and brittle. Take here, for example, in this imaging showing an ivory vertebrae due to a likely Paget's disease. And here we have histology of Paget's disease, revealing a mosaic pattern of lamellar bone. Note this jigsaw puzzle, this mosaic pattern. Clinical signs of Paget disease of the bone include hearing loss, an enlarging head size. Having to obtain bigger hats is a key finding in the history. Bone pain and microfractures. Patients older than 40 years old are more likely to have isolated increased alkaline phosphatase, which is the most prevalent cause of isolated raised alkaline phosphatase. Patients with Paget disease of the bone also tend to have lion-like faces with involvement of the craniofacial bones. Treatment of Paget disease of the bone includes calcitonin and bisphosphonates. Calcitonin inhibits osteoclast function. Bisphosphonates induce apoptosis of osteoclasts, right? These medications are all about stopping those osteoclasts. Complications of Paget disease of the bone include osteosarcoma and high output heart failure. Here we can see imaging from a patient with Paget disease of the bone. This was a 92-year-old male, and there was an incidental finding marked by the thickening of the calvarium. And here we have a biopsy showing extensive deposition of osteoid with distortion of the bone structure and multinucleated osteoclasts. Now this is important. Osteomyelitis. Osteomyelitis is an infection of bone. Osteomyelitis is most commonly caused by bacteria and arises via hematogenous spread. While open wound bacteremia in adults typically seeds the epiphysis, transient bacteremia in infants usually seeds the metaphysis. Staphylococcus aureus is the most common cause of osteomyelitis, accounting for 90% of cases. Common causes of osteomyelitis include Staphylococcus aureus, right, 90% of cases. Neisseria gonorrhea, which affects sexually active young adults. Salmonella, Pseudomonas in diabetics and drug users. Pasteurella, which is linked to a cat or dog bites and scratches. And Mycobacterium tuberculosis, which typically affects the vertebra. Clinical characteristics of osteomyelitis include bone pain, signs of systemic infection symptoms, X-rays showing a lytic center surrounded by bone sclerosis. Lytic focus is called sequestrum, and sclerosis is called involucrum. Diagnosis of osteomyelitis is made by blood culture and or bone biopsy at the site of the lesion. Here we have osteomyelitis of the first toe. You see that there? And here we have some representative sections from histopathology associated with osteomyelitis. I just want you to note the various inflammatory cells and the bony infiltrate. And here we have necrotizing granulomatous inflammation. And here we have low power of osteomyelitis, this ill-defined granulomatous inflammation with Langerhans giant cells, highly suggestive of a mycobacterial infection. You see the giant cells? Near the right side, kind of near the bottom-ish. Now this is important. Avascular necrosis. Avascular necrosis is an ischemic necrosis of bone and bone marrow caused by trauma or fracture. Risk factors for avascular necrosis include steroid use, sickle cell anemia, Caisson disease, right, the acute decompensation syndrome, that deep sea divers may experience. Complications of avascular necrosis include osteoarthritis and fractures. Avascular necrosis can be seen here in this image, showing the nuclear magnetic resonance of avascular necrosis of the left femoral head there. And here we can see radiography showing necrosis of the left femoral head in a man with HIV, AIDS. And here we can see total avascular necrosis of the right humeral head in an 81-year-old female with diabetes. And here we can see avascular necrosis of the right knee of an adolescent. And here we have the head of a femur with some synovium attached to the bottom and a ligament of the head of the femur. This was taken to treat avascular necrosis. Now let's get into bone tumors. Now this is key. This has a classical, pedunculated, well-circumscribed finding. You'll probably be asked to recognize this. It's an osteoma. Osteoma is a benign tumor of the bone. Osteoma most commonly arises on the surface of facial bones. Osteomas are associated with Gardner syndrome. And here we have another image showcasing a osteoma, and another image showing an osteoma. And this is an osteoid osteoma, which is a subtype of osteoma. In osteoid osteoma, reactive bone forms a ring around a benign tumor of osteoblasts, which produce osteoid. Osteoid osteoma occurs more commonly in young adults, younger than 25 years of age, and is more common in males. When osteoid osteoma develops in the cortex of a long bone, such as the femur, it causes bone discomfort that can be managed with aspirin. Imaging of osteoid osteoma classically reveals a bony mass smaller than 2 centimeters with a radiolucent core from the osteoid. The main differential to osteoid osteoma is an osteoblastoma. Osteoblastomas are similar to osteoid osteomas. However, osteoblastomas are bigger. How much bigger? Well, they're bigger than 2 centimeters. They may develop in the vertebrae and manifest as bone pain that is not relieved by aspirin. Here we have an image of a micrograph from a patient with an osteoid osteoma. And here we have imaging of an osteoid osteoma and more histology. Note the woven bone and differentiated osteoblasts lining the osteoid. And this is an osteochondroma. An osteochondroma is the tumor of bone with an overlying cartilage cap. Osteochondroma is the most common type of benign tumor of bone. So all you future orthopedic surgeons out there, you might be cutting this out of your patients. Since the bone and marrow space are one continuous structure, the tumor is the result of the growth plate projecting laterally. Overlying cartilage can transform into chondrosarcoma on rare occasions. And here we have imaging, a lateral radiograph of the knee demonstrating ossification in a patient with peritendinous tissues in a patient with osteochondroma. Now this is osteosarcoma. Osteosarcoma is the malignant proliferation of osteoblasts. Take a look at this image here to the right. This is an H&E micrograph at some magnification, about intermediate, showing a high-grade osteosarcoma. By definition, osteosarcomas form osteoid, which is the organic extracellular component of bone, that pink stuff back there, and the bland homogeneous H&E stain. Osteosarcomas typically develop in the metaphysis of long bones. For example, the proximal tibia or distal femur. Risk factors for osteosarcoma include familial retinoblastoma, Paget disease, and radiation exposure. The peak incidence of osteosarcoma is seen in teenagers and less commonly seen in the elderly. Osteosarcoma typically presents as a pathologic fracture or bone pain with swelling. Radiology of osteosarcoma classically shows a destructive mass with a buzzword sunburst appearance and elevation of the periosteum. Diagnosis of osteosarcoma is made by biopsy, which will show pleomorphic cells that create osteoid. And here we have histopathology of an osteosarcoma. Note the tumor cells with high nuclear pleomorphism, but relatively less so in cells that are entrapped in the neoplastic bone matrix. And here we have a high magnification micrograph showing the osteoid formation in an osteosarcoma. And here we have the various predilections of osteosarcoma, like where they're more likely to show up. And here we have various stains of an osteosarcoma and osteochondroma tissues. Now this is important. Giant cell tumor of the bone. Giant cell tumor of the bone is composed of multinucleated giant cells and stromal cells that occur in young adults. Giant cell tumor of the bone typically arises in the epiphysis of long bones, usually the distal femur or proximal tibia. Radiology of giant cell tumor of the bone classically shows a buzzword soap bubble appearance on X-ray. Giant cell tumors of the bone are locally aggressive and they may recur after surgical removal. Here we can have giant cell tumor of the bone, right? The micrograph. Note all those giant cells there, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. You see them? Do you see the giant cells? Do you see the giant cells? Now, Ewing sarcoma. Ewing sarcoma is characterized by the malignant proliferation of poorly differentiated cells. Ewing sarcoma typically affects male children under the age of 15 years old. Ewing sarcoma generally manifests in the diaphysis of the long bones. Radiology of Ewing sarcoma classically has a buzzword onion skin appearance on X-ray. Onion skin Ewings, onion skin Ewings, Ewings onion skin, Ewings onion skin. Diagnosis of Ewing sarcoma is made by biopsy that results in the revelation of small, round, blue cells that look similar to lymphocytes. Malignant cells of Ewing sarcoma stain positive for CD99. You'll have to know that. Ewing sarcoma cells stain positive for CD99. Genetic tests for Ewing sarcoma tend to show EWSR translocations, such as EWSR Fly1. Ewing sarcoma is treated by chemotherapy. And here we have the various distribution of Ewing sarcoma and some more histology of Ewing sarcoma. Note that this was the PAS stain. And it's important to note that FISH, fluorescence in situ hybridization, can be a useful tool for noting the rearrangement of EWS gene in Ewing sarcoma. As you can see here, EWSR1 gene at 22q12, note the breakpoints there, right? Particularly in A. And then the other panels are just showcasing various magnifications of Ewing sarcoma. Now, chondroma. Chondromas are benign tumors of cartilage. Chondromas typically develop in the medulla of the small bones in the hands and feet. And the chondrosarcoma is a malignant cartilage-forming tumor. Take, for example, this image to the right here. This is a chondrosarcoma that was obtained from a patient's chest wall. Chondrosarcomas tend to develop in the axioskeleton or pelvic medulla. Diagnosis of chondrosarcoma is made by biopsy, which shows malignant chondrocytes. And then we have a chondrosarcoma here, various panels showcasing a pelvic tumor mass and skull metastasis that revealed a chondrosarcoma. And here we have a picture of a patient's lip with a metastatic chondrosarcoma. And here we have an MRI of a chondrosarcoma affecting the left pelvis. Now, this is important to note. In regards to metastatic tumors to the bone, primary cancers are less frequent than metastatic tumors to the bone. Metastatic tumors to the bone typically show osteolytic or punched out lesions on an X-ray. Notably, metastatic prostate cancer to the bone produces osteoblastic lesions. And with that, you completed a very important topic because there are multiple symptoms and multiple systems that were discussed, right? You have this, you got it down. I believe in you. Keep up the good work. Keep making everybody proud. You got this. And until next time, see you later.